guys, welcome to the Man Medicine Podcast, where we talk about how men can optimize their health, escape the collapsing U.S. healthcare system. I have the pleasure of being back yet again with Dr. Max Draper, lead clinician from AlphaGenics, and we've decided to knock out a few podcasts this week. This is our second one, and we're going to talk about something that perhaps doesn't get talked about as much as it should, and that is who should not use testosterone therapy, or what are some of the perhaps contraindications to beginning testosterone therapy. All over the internet, everybody talks about how wonderful testosterone therapy is. And don't get us wrong. I mean, we are big proponents of testosterone therapy for the right patients and for the right indications. But that doesn't mean it's for everybody. And you certainly, if you look on Instagram, watch YouTube videos all day on this subject, you might get the false impression that really every man should be on testosterone therapy. And that's really not the case, is it, Max?
Yeah, it's probably not a good business podcast for us, is it?
It's terrible.
Yeah.
If you're trying to make a lot of money in a cookie cutter clinic, you don't want to listen to either one of us.
Yeah, exactly.
Yeah. That's not how we operate.
Yeah.
But it's true, isn't it? I mean, the if you didn't know anything about this subject and you just did some basic internet searching, and certainly if you spent any time on social media or on forums, I think you might get a slightly biased, and I mean that tongue in cheek, it's a bit sarcastic, so a lot more than slightly biased, but a more biased impression of what TRT can do and who should take it, because everybody talks about the positive sides of TRT, but there are obviously downsides, like major downsides to going down this road that I don't think get talked about enough.
Well, I think, simply put, if I hadn't needed it, I wouldn't be on it as well. That's the other thing to consider. It's kind of like, if I had naturally good levels and I felt great, I wouldn't have ended up having to inject for the rest of my life,
Yeah, exactly. And that's, in an ideal world, very few, if any men would require testosterone replacement therapy. And, you can say that about all endocrine hormones, right? In an ideal world, everybody's thyroid would function exactly as it should. Everybody's pancreas and adrenal glands would behave themselves and would allow you to maintain healthy levels throughout your lifespan. And it just wouldn't be an issue, but that's really not the case. The big problem now, or one of the major issues, is the fact that we're seeing objectively low testosterone levels, with symptoms in many cases in younger and younger men. And that's the one area that it still makes me a little bit uncomfortable. And it's a question that, nobody can definitively answer, the question of when is the right age to start treating a man.
Mm-hmm.
It's a tough question, right? It's not, there's not a black and white answer to that question. So maybe we can just dive into that at first, and maybe you can talk a little bit about your approach. It's very easy. If I had come to you and I was in my late 30s and, pretty classic symptoms, pretty low numbers, I don't think it wouldn't have been a big diagnostic dilemma.
Mm-hmm.
And I think we could have had a fairly short conversation. But what if I came to you at 22 with a total T of 300 and pan positive on my symptom scores? It's a little bit of a tougher nut to crack. How do you go about that? What's your approach?
Yeah, and I think we've probably both been there, and I've been there several times now.
We're all the time.
Yeah. And I think even more commonly, you're seeing guys in their late 20s who's not had a family and have no obvious cause for a deficiency as well. They haven't got, like, for example, I've had a few young guys, early 20s, like we say, who have, rampant inflammatory conditions or, for example, thyroid disorders. And it is like you say, if they've got, let's say you could take two arms to this. They've got an obvious reversible cause, or they've got, either a non-obvious cause or something that's irreversible. And again, you've got to factor in the fertility for these young guys. So it's one of those ones that keeps you up at night. It's one of those ones where it's not a short conversation, and often it involves several conversations to go through the details,
Absolutely.
I think in terms of the younger guys as well, say the early 20-year-olds, then it's all about the actual consultation and delving into the history and trying to work out what is causing this low testosterone. Because like you've spoken before about on this channel, there's genetic causes, there's other endocrine disorders, there's structural abnormalities with the brain or the testicles, all of which really have to be flushed out and considered, I would say, before you even consider treatment. Do you know what I mean? Because you've got to get a working diagnostic.
Absolutely.
Yeah.
Absolutely. Yeah. I mean, I go through the same thought process. If there's an irreversible condition, whether it's a primary or secondary process. So, for example, a primary testicular issue. If a young man, obviously, I mean, an orchiectomy, bilateral orchiectomy, obvious, that's not a diagnostic dilemma there. In a man with a prostate cancer or, trauma, actually. So we have a whole population in the U.S., obviously, and in England, military service members in IED blasts. And, I've seen young men like that who have lost their testicles from blast injury. So that's obvious, right? That is not a diagnostic dilemma. If there is a obvious irreversible, especially structural issue, which would land them in the sort of the primary hypogonadism, part of the algorithm. That part is easy. The same with secondary too. Like many of these guys, if they didn't have trauma to the pelvis, they have CNS trauma, they have multiple TBIs, either one or more like very serious TBIs or a whole series of very minor TBIs, which have taken a toll over the years. And so, clearly that's an irreversible condition. And regardless of age, those men will need treatment of some kind. The nice thing, obviously, is they presumably still have functioning gonads. And so you maybe have some more options in terms of treatment, with HCG and SERMs, even though we're not huge fans of those. But obviously, if fertility is on the table, which it usually is for these young guys, then we have to consider those sorts of things. So yeah, you're right. It is absolutely, it's easy, or certainly much easier when there's an irreversible condition. It's no different, in my opinion, than, again, if you developed severe Hashimoto's thyroiditis and, subsequently became hypothyroid, regardless of age, there are infants that are put on Synthroid because of hypothyroidism. So nobody would question that. And, this is another endocrine hormone that obviously needs to be replaced. If the body has there's no hope of it ever being restored to at least semi-normal levels, then yeah, absolutely, you have to pull the trigger. But you're right. That's the hard part, is when we get into these cases where there's no obvious pathology that we find. And I think, I don't want to divert too much on this, but this is where some of these cookie cutter clinics fail in many, many cases. Low testosterone, suboptimal androgen levels, hypogonadism, whatever you choose to call it. This is an endocrinopathy, and there is a list of potentially serious but thankfully rare serious medical conditions that need to be evaluated and worked up prior to the initiation of therapy. There needs to be at least some nominal attempt at a diagnosis. And it's shocking to me still, like I will see guys that are started on T and they've never had an LH and FSH level done.
Yeah. Or a
prolactin. Like that's kind of a day one thing. Yeah. And it just, it comes from these clinics that are just testosterone mills, and they're doing a major disservice, obviously, not to mention medical malpractice, in my opinion, because there's a small percentage of those men that will have prolactinomas. They may have a testicular cancer. They may have a big varicocele, or I don't know. They may have something seriously wrong with them that has been missed. So you don't want to ever do that.
And the big issue with that as well is the fact that if you don't get them prior to treatment, like for example your LH and FSH, you're never going to be able to get an answer from those again. Yeah, you may
never be able to. I mean, they would have to come off of testosterone, obviously, and then there's no guarantee, obviously, that they're going to get those LH and FSH levels back to their pre-treatment levels, and they might, but it could take a year or more. Sometimes it just depends on the case. So, yeah. Having said that, there is a medical workup. There's a reason that we go and do all this CME training to practice this type of medicine. This is not cosmetics. This is medicine. We're practicing endocrinology within our scope. We're not trying to be endocrinologists, but we are practicing a within a niche of the field of endocrinology, which honestly, as general practitioners, you and I both formally trained in that specialty, should have a good grasp of the endocrine system. Unfortunately, it's kind of spotty. Not all GPs do, and I don't fault them for that. But anyway, yeah, I guess what I'm getting at is there needs to be a proper medical workup. Now, many times with these guys, there's, we say that there's no obvious cause, but when you sort of look at these guys and, many of them carry excess body fat, and not just subcutaneous body fat, but visceral body fat. And that's where the MOSH syndromes, morbid obesity, secondary hypogonadism, comes in. And that name is a bit misleading. The term morbid obesity, I think, makes people think of just this massively obese person riding a scooter at the Walmart, which is what we see here in the States. But that's not really the case. The amount of visceral body fat that you need to negatively impact hormones is maybe not as high as a lot of people think. You don't have to look like, somebody on what is it, the My 600 Pound Life show that we have here. I don't know if you have an equivalent in the UK, but yeah, you don't have to be 300 to 500 pounds. You can just be somewhere between 22 and 26% body fat, for example, which with regular clothes on, nobody would bat an eye, but yet you have fatty liver disease, you have insulin resistance, you're pre-diabetic, you have high triglycerides, all of your inflammatory markers are above where they should be. And of course, that's going to negatively impact the hypothalamus. So many of those guys do have that phenotype, but then it becomes, of course, like a chicken and the egg phenomenon, right? Like how much of this is from the low T, how much of this is diet, lifestyle, et cetera. Obviously, given enough time, it's usually both.
Yeah.
So that's a hard one.
The vicious cycle of low testosterone.
Yeah, it's a vicious cycle, right?
Yeah, worse.
So it's hard. Yeah. I know we've talked about this before, but it's sort of like it's the eternal question of, do you start therapy in order to help them lose weight, or do you really push them to lose weight first, and then if they fail or if they don't recover, then do you start therapy?
And I think that's partly, and I think it should be determined partly by age as well, and fertility. And, potentially you'd feel a lot more comfortable if someone's had their family, they don't have any fertility concerns, and they're in that picture where it's a chicken and egg. Will TRT help them improve all of these aspects, or do they improve all of those aspects before rechecking, let's say? But if it's a young guy in that situation, you'd be far more keen to go down the route of try and tackle these things before signing up to what is potentially a lifelong treatment, which does complicate fertility. Yeah,
it sure does. And I do struggle with that. And that's obviously the way that you approach, that's going to obviously be on a case-by-case basis. Yeah, absolutely. Let's talk about the fertility thing just briefly, because that's one of the major things with these young guys. It's really important, I think, that guys understand that testosterone therapy will compromise fertility. And of course, you can get on the forums and you can get online and you can find good scientific papers that say, it's possible to remain on TRT and simply add in HCG and perhaps recombinant FSH, and you will still be able to remain fertile. And it's, in many cases, that is true. I actually have done it myself. I'm currently on HCG, right? And you haven't discontinued your testosterone. But I think it's really important for young men, especially, to understand that that's not a guarantee by any means. And really encourage young guys, if you're even entertaining the possibility of TRT, to get a baseline semen analysis to find out what your counts are like. Because these days, it's well documented that male sperm counts all over the world, they have been plummeting for decades. And it seems like every time a paper comes out on this, it's just lower and lower and lower and lower. The WHO has talked about it. They use a cutoff of 20 million sperm per ml as sort of the lower limit of normal. But the fact of the matter is that probably less than 40, as that number decreases, you start to see some, decreased fertility rates. Nobody knows exactly for sure where that starts. And there's obviously a lot of factors. So, for example, if a young man comes in and he's got 200 million sperm on his analysis, I feel a little bit better about that, because even if that number is cut in half, which it certainly could be, if you go on TRT with a fertility protocol, usually HCG plus minus recombinant FSH, you're not going to stay at 200 in many cases. It will still drop. But if you drop from 200 to 100, you're still going to be fertile, right? You're still going to be able to have children. It's usually that's you haven't gone off that cliff yet. But if your baseline is 20, which many guys it is, and then now we cut you down to 10, even with a good fertility protocol, which I've seen. So now 10 million sperm, that's a problem for routine, conception. And you might be looking at having to go down the IVF route or the intrauterine insemination route. So having that baseline semen analysis, I know it's awkward and embarrassing. You and I have both had to go give samples, not together, but in the course of like getting our wives pregnant, because we both had primary hypogonadism, both had fertility issues as a result. We've had to go do that. It's awkward. Nobody wants to go do it, but it's such a valuable piece of information for me as a clinician. And I know you feel the same way about it. If I see a nice solid number there, good, I feel like they have a good buffer, then I feel like we have a little bit more wiggle room to perhaps treat with the addition of a fertility adjunct, as I mentioned. But if they're on that borderline, that also really makes me a bit uncomfortable. It's not that I won't do it, but it's just really important that patients understand that. You hear these stories on the forums and on the internet of fertility success while on TRT, but you rarely hear about guys don't really take the time to get on those and talk about the failures, which we see as clinicians, but are not broadcast on the internet. So,
well, as well, the other thing is to consider is if you can avoid TRT through natural, methods of improving it, like we said about get that visceral body fat down, is usually one of the main ones. And then you talk about sleep, stress reduction, whole food diet, avoiding EDCs and things. But
all important.
Yeah, but the other thing just is life's a lot easier fertility wise if you're not on testosterone.
My gosh.
It's like
absolutely
FSH injections, HCG injections, you're already injecting testosterone. HCG, even with FSH, is not quick, necessarily.
No.
It's not like next week you're going to have a great sperm count. It can take even several months to fully respond. So it's all of these are complicated steps rather than potentially avoiding TRT if you can. And being in a much more easy space. Yeah,
absolutely. I tell guys exactly. That's almost verbatim what I said. I said testosterone it complicates your life, and I don't want to complicate your life any more than it has to be complicated. It is a pain in the ass, and I both figuratively and literally in some cases to have to inject 3 times a week. Not only 3 times a week, but for the rest of your life. So are you going to pull the trigger on that and, be obviously dependent on exogenous testosterone? These days, if you take good care of yourself, barring accidents and bad genetics and just bad luck, I mean, most men, if they do a good job, can certainly expect to live into their late 80s. So do you want to commit to 50 years or 55 years of supplemental testosterone? And every time you go on a trip, you have to think about packing your testosterone and, what do you do if you forget it? And I mean, it complicates your life. It's a chronic, you're signing up, you have a chronic medical condition. And so, I agree. If there's any way to restore at least enough to make a man feel better for a period of time and maybe delay that, I absolutely, I support that. And when they're under 30, if there's any opportunity to do that, I really try to push guys to doing that. The problem is, one, it's very difficult to make some of the lifestyle changes. And it's actually really disappointing when you look at some of the studies about, how much testosterone improves even after massive weight loss. We've talked about this
Yeah.
before, but people that have had gastric bypass surgery, for example, there's actually a paper that just came out recently about this, and I've talked about it before. And there's other papers that have shown exactly the same thing. Is first of all, there's a subsegment of those men who they have lost. Some of them lost 50 kilos, over 100 pounds of body fat, and they're still hypogonadal.
Yeah.
And they're still hypogonadal. But there are men that, have had, they say up to 40% improvements in their total testosterone levels, which sounds great. But of course, if your baseline is 200 and
Yes.
you gain 40%,
Yeah.
that may or may not impact how you feel. It may or may not be sufficient to alleviate your symptoms. And in many cases, it's not. So
Yeah. Well,
it's very disappointing.
Yeah, it makes you think two things. One is sometimes in those studies you can see that they've lost weight, but they've not necessarily done all of the other, resistance training,
Precisely.
reduce systemic inflammation. The other aspect to it is if they've been obese for a prolonged period or had excess body fat for a prolonged period, have they irrecoverably affected the system?
Exactly.
And that's what you wonder about as well. In which case, then you're kind of looking down the barrel of TRT again, potentially, know?
And it makes you wonder in those studies, the men that still remained hypogonadal and did not have major changes in their T levels, that has to be the mechanism, that if they've had 2 decades of chronic hypothalamic inflammation and they're just done, from that standpoint. They may not be able to recover that. I don't know that anybody's ever figured out the mechanism there, but it does make sense. The longer a pathological condition exists, obviously, in many cases, the tougher it is to completely reverse that. Now, in my clinical experience, I haven't ever seen any papers on this, but the younger a man is, I have seen much better improvement in numbers when they lose weight, as opposed to, say, a 60-year-old man. It's highly unlikely that they will go from 200 to even like 500 or 600.
Yeah.
It's not impossible, obviously, but a 22-year-old very well could.
Yeah.
And depending on that guy's androgen receptor sensitivity and a host of other things, that might be sufficient for him to feel and function, adequately, at least for 10 more years, at least, which, is going to be obviously preferable to jumping on the TRT bandwagon. But everybody wants the T, even the young guys. They see it on Instagram. We talked about it on our last podcast. It's some unrealistic expectations. If getting back to fertility, if there's any thought of fertility within the next certainly less than 5 years, I strongly discourage guys from starting TRT, or at least if they're going to do it, they really need to understand what they're getting into. I don't ever want a patient to ever say, well, you never told me about blank, 2 years or 3 years into therapy. And if there's any way to avoid that.
Well, how many guys as well and this is why Andrew's pushing the point as well, is that how many guys have you seen come from different clinics? I had one last week who basically he was told, when you want kids, you just stop the testosterone and you'll be fine.
Yeah. I've heard that too.
Okay.
Yeah.
Good luck with how you'll feel, and assuming the system kicks back into gear fully and all of the other variables there. It's kind of like, I don't think they've really given you due diligence.
No.
Really.
It's malpractice. I mean, it's malpractice to do that. It's not okay. Not okay, in my opinion. But Max, one of the things that you'll see done, and I have done this, I think you have as well, is using SERMs as an alternative, at least for a short period of time, in some of these young guys who need to preserve fertility, and also who perhaps need to lose a lot of weight to perhaps help with, some of their symptoms, maybe delay putting them on TRT. Like, what are your thoughts about it? There's obviously enclomiphene. Clomid has been around for a long time. There are some guys that have done well on HCG monotherapy. All of these there's pros and cons, obviously, to both of those drugs. How does that fit in for you when you talk to a young guy?
Yeah, I think it's an option I've looked at, like, as a short-term solution, particularly for people who are actively trying but having roti and things. I mean, the issue is, and with the SERMs is that on paper, yeah, they can look really nice. You know, you get a nice testosterone level, and you can see, you can think on paper it's working, but actually in reality, the person doesn't feel any better, or at least doesn't feel fully better. So they're a bit limited in terms of symptom resolution, I find. But also, I'm just not a fan of, and I think you're the same, of messing with receptors, hormone receptors, you know, messing with hormone enzymes, that sort of play. It just doesn't sit right with me. But short term, yes. HCG monotherapy, I don't go down that route. I think people forget that it suppresses your own LH and FSH if you're giving it enough to stimulate enough testosterone response. And plus, you come back to this idea of what are we aiming for? Well, yeah, we want to maintain fertility, but we also want to feel better from low testosterone. And HCG monotherapy, you don't tend to see that symptom resolution. It's
variable, isn't it? It's highly variable.
Yeah.
And you will hear case reports, and there are obviously case reports in the literature that exactly what you just said. On paper, the numbers look good. Sperm counts can be maintained with monotherapy. You know, Vigorous Steve has been very vocal about his fertility protocol, and he did exceptionally well, I think, especially for a guy who's used androgens for over a decade, discontinued, and then he used both HCG and recombinant FSH, if I'm not mistaken, and was able to achieve pretty good T levels. I think he was talking about being consistently in the 800s. He obviously stayed super jacked, but you have to be careful, I think, about using him as the norm. He's a guy who's exceptionally fit. He does everything else right. He has low body fat. He already started with, you know, an incredible amount of muscle tissue to begin with. So I think we have to be careful about some of the examples that we see on the internet and applying those to the, you know, the sedentary 23-year-old male with 26 or 27% body fat. They may not get the same results, obviously.
But also, the guys that we're starting out on treatment might be in a pretty bad place low T wise. And if they said to you, is this monotherapy with HCG, is it going to make me feel better? And it's just kind of like, maybe, maybe.
Yeah, or maybe for a while.
Yeah.
Maybe for a while.
Yeah.
So it really is. Yeah, I agree. It's not, there's no magic bullet for this. That's the problem. There's just no magic bullet for this. Everything is a trade-off. And you can say that pretty much about all of medicine, in my opinion. You know, every drug has side effects. Every drug has limitations. So it's difficult. It gets back to also the fact that you generally, unless you have, again, structural pathology, your sperm count is often a reflection of your overall health as a male. And so, again, we're focusing on, you know, the hormonal ways to manipulate this and to improve things. And obviously that's important, but you know, the cornerstones are the cornerstones. You have to lead a healthy lifestyle. You have to have a healthy vessel in order to make healthy sperm. And you know, that applies obviously to all areas of life. So it's not enough just to inject HCG and FSH and take enclomiphene and do all these sorts of things. You have to do all the other things, because sometimes what I've seen is an improvement in total sperm counts, but the sperm quality remains crappy. Motility, you know, they have, you know, deformed sperm that, that they have a large number, but they still are unable to create a pregnancy because they just sort of lay there, you know, sluggish. And that's not a hormonal issue in many cases. There's DNA damage, there's oxidation, there's many things. It's in the way that there's a whole pathway for the creation of a healthy sperm, and there's so many things that can go wrong along the way that don't have anything to do with intratesticular testosterone, for example. So,
well, even on the subject of fertility, before we move on, it's kind of like we don't understand a lot of it. You speak to fertility doctors and they say, we don't understand why someone can have 25 million sperm and have complete pregnancy issues. You know, they can't get their wife pregnant, whereas someone else with 8 million might get their wife pregnant within 3 months. You know, so there's more detail going on. So you talk about it in general terms, but there's so much more specific detail that, and some of which we don't understand. Like you said, we know about motility and things, but even then there's sort of compatibility issues that people seem to be.
Absolutely. And we're not talking about it on this channel, but there's the female factor.
Yeah.
A whole host of female factors. So I encourage patients, if they do have fertility issues, to also see, if they're a male, to see an andrologist, see a urologist. There's a basic workup that needs to be done, but their partners, their spouse, also needs to be seen by a reproductive endocrinologist. Certainly, if they've been having unprotected sex for over a year with no results, that's an indication for a referral to a fertility specialist for sure. But I say it's if you're over the age of 35 as a female, I tell them not to wait a year. The clock is ticking. It's perfectly appropriate, in my opinion, if you're over the age of 35. If you've been trying for 6 months even with no results, go get seen, because every year that goes by, pregnancy rates go down. So I know it's a little bit off topic, but get your specialists involved if things are not happening as they should.
Yeah.
So,
and just as a global statement as well, in terms of improving sperm count and improving testosterone levels naturally, like you said before, it seems grossly, or generally, let's say, about reducing inflammatory burden. And
it is. Absolutely.
That's kind of the take-home point, which is predominantly losing visceral body fat.
But everything comes back to body fat.
Yeah.
It's not like broken records, but really it is the root cause of so many of these issues. Just visceral body fat. And easier said than done, obviously, but that has to be reduced.
Yeah.
So
yeah.
Well, should we move on to something? I think we beat fertility to death.
Yeah, we've already had a podcast on it as well. People will be sick of hearing about.
I know, they're so over it.
Issues.
Yeah, but it's a subject that's near and dear to both of us, right? Because we both have had fertility issues. So, and thankfully have been successful in overcoming them. So, so all good. Maybe let's briefly touch on what the Endocrine Society and some of these other large medical societies say are contraindications to testosterone, and because in some cases they're not necessarily, right. So one of the first one that comes up is acute prostate cancer, and you have to I guess decide what do you mean by acute prostate cancer, but that, as we've talked about in other podcasts, is being chipped away at. Now, I don't think there's anybody out there, including you and I, that would start testosterone therapy on a newly diagnosed prostate cancer that is currently undergoing treatment of some kind.
Yeah, exactly. That's what
I don't think I wouldn't do that for no other than medical legal reasons. And I would only even entertain that with the blessing of the patient's urologist and oncologist, because that is still an area of debate. Now, where the debate is largely over is in these guys who obviously have been successfully treated. They've had a PSA of 0, like, for example, after radical prostatectomy, over the course of a couple of years. I don't think there's much doubt there that we could at least have that conversation. But if it's early on and they're actively undergoing treatment, I would defer that to their urologist. If they want to pull the trigger on that, I would do that. So I think we're both, that's just sort of common sense. I think we're both on the same page with that. Yeah. It's, where the gray area now is like, what do you do with somebody who has stage 4 disease, has been treated, but now they've got a met like to their lumbar spine that's stable, and it's been stable for a couple of years. They're highly symptomatic. There are urologists out there that will treat those patients. And honestly, I would too, but I would still want to have the blessing of the subspecialists as well.
Yes. Yeah, exactly.
Because if something goes sideways, you will be blamed for that. And so
they'll point the finger.
They'll point the finger at you. So there is a little bit of CYA involved in that. The other contraindication that they talk about is men with severe lower urinary tract symptoms, aka like severe BPH symptoms. So what do you think about that?
Well, it's an odd one that's still in there, really, because from my understanding of the data on lower urinary tract symptoms and testosterone is that TRT can actually improve looks.
Right, exactly.
So it's a bit of a strange one, and it's certainly we don't have anything to point out that it accelerates BPH. So
No.
it's not really
Mm-mm.
it's not research based, I would guess.
No, it's
Yeah.
not. I don't have, and they, defines, what are severe urinary
Mm.
tract symptoms. If you have severe symptoms, you probably need, and certainly medications, if they're not working, you might need surgical intervention. You might need a
Yeah.
TERP.
Yeah. Yeah.
And that's, testosterone is sort of, I think, somewhat neutral in that area.
Hmm.
I have seen guys who, if they've had a low T for a really, really long time, the prostate does sort of, it doesn't atrophy necessarily, but it certainly doesn't grow as fast as it would with a healthy T level, because it's natural. They say, as an older man, the only things that keep growing are your nose, your ears, and your prostate. There's
Yeah.
probably some truth to that. So, what I have seen is a bit of a volumizing effect. So it's sort of like watering a dead plant, where the prostate will enlarge a little bit, and there could be some relatively minor symptoms from that. You might see a slight bump in the PSA, but then it levels out to a new baseline. So you just have to have that conversation with patients.
And that's that saturation theory that
it's a saturation model. And if they're below that, it's natural for the prostate in many cases to shrivel up. But a lot of times it doesn't. Some of the biggest prostates I've ever felt on a physical exam have been in elderly men with very low testosterone levels.
Yeah.
Huge prostate. So anyway, it doesn't always work out.
And some guys I've seen have actually had, nocturia, so nighttime peeing issues when they've had low T, but that's primarily because their sleep has been disturbed a lot.
Precisely.
So when you wake up a lot and you end up being like, I'm just going to take a wee and then come back. So actually when you go on TRT, sometimes that can improve because they sleep better. And so they're not waking up all the time and ending up peeing. So I've seen that as well.
Totally.
Yeah.
The other one in the guidelines is if they've had what they call a recent cardiovascular episode. So recent heart attack or recent stroke. And by recent, they usually mean like within about 6 months.
Yeah.
So how do you feel about that? How do you approach that?
I think I would be fairly comfortable if everything was stable to go down the route of TRT if they were symptomatic of low testosterone, because like we said before, and I think we mentioned in the last talk, is it's not bad for your heart, and we need to get kind of over this. I think it's a completely different conversation if they have unstable heart disease or unstable heart failure, which is pretty obvious. But in terms of a stable cardiovascular disease, then if anything, you're going to potentially improve how they feel and function.
We have to realize too that some of these recommendations with these time frames, like 6 months, for example, after a myocardial infarction, where does that number come from? It comes from, well, we know where it comes from. It's made up, and it's sort of expert opinion. It's not based off of studies, and so we just have to take that into account. Again, there's nothing wrong with getting the patient's cardiologist involved in this decision as well. Not all cardiologists are vehemently anti-testosterone, and the paradigm is changing. So I agree with you. I think if otherwise stable, again, that 6 month is an arbitrary thing. You have to have a good conversation with the patient. It's going to be on an individualized basis. Obviously, if they're still having angina, that's a problem, potentially. So they need to be medically optimized outside of the realm of testosterone, I think, first. And then obviously they can't have decompensated heart failure like we talked about in the other podcast. But that's I consider that to be a relative contraindication, not an absolute by any means. Now, does that mean I'm not starting TRT on my patients in the hospital? Like that's let's not get that aggressive about it. At the same time, is 3 months, if someone's doing well after a stent, for example, at 3 months, how is that different necessarily than at 6 months? It's a bit arbitrary, I think. And if they're symptomatic, and again, if you do things prudently, I think it's fine. So
it's not it's like you said, it's not based on any research paper. I think it's probably just being cautious, but you'd say that there's not really evidence base for that cautiousness, so
Yeah, precisely. Yeah, precisely. So the other ones that they talk about here, I've got the list up here in
Mhm.
front of me, and they're all sort of common sense. But they say untreated severe obstructive sleep apnea,
Yeah.
and you know what? I agree with that. That makes sense. I mean, you need to if you have untreated severe obstructive sleep apnea, you need to fix that ASAP, regardless of whether you're going to get on
Mhm, mhm.
TRT. I don't care what else is going on in your life, what other problems you have.
Yeah.
That needs to be addressed. So I certainly don't have a problem starting TRT at the same time as treatment for the sleep apnea. But I would be a bit cautious about somebody who has severe sleep apnea, and what I mean by that is, perhaps they also have pulmonary hypertension as a result
Mhm.
of that. They've got right-sided heart failure or a big dilated right ventricle. Um, that needs to be addressed. That
Yeah.
needs to be
Yeah.
looked at. I might hesitate to start somebody on TRT.
Well, you're implying again, it's kind of that instability that's going on in terms
Right.
of physiology. Like severe sleep apnea,
Mhm.
untreated,
Yeah.
is quite a significant condition. That, yeah, I mean, like you said, you'd need that to get it managed. I mean, arguably, if their sleep apnea got better, their testosterone levels might improve.
Mhm.
If it's severe, they might see a jump in their testosterone. But yeah, if they get treated, then there's no delay in necessarily in starting treatment at that point. Yeah.
Mhm. Yeah, precisely. So, yeah, I think we're on the same page with that. The other ones they say prostate abnormality, and this is very arbitrary. PSA level greater than 4.
Hmm.
Just they send them to a urologist before you would even entertain starting a testosterone therapy. So,
Yeah.
what do you feel about that?
Well, do you guys not have age ranges for your PSA and things like that? That's what we have in the UK, where
Oh, we do.
yeah,
Yeah, yeah. And there's some you can look at charts and see, and there's an expected rise in PSA, but
yeah,
I think you have to be a little bit cautious using those because not all men. You really would. You'd love to know what their baseline was
yeah, yeah,
at some point, but that 4.0 is obviously an arbitrary number. It's
yeah,
based off old AUA guidelines about from to give us primary care doctors sort of a
yeah.
benchmark of when to pursue a workup and when to be worried, when to not be worried about prostate cancer, that sort of thing. But we
Yes.
do have to remember that it's an arbitrary cutoff,
Hmm.
and if I had a man with a PSA of 4.2 that has been 4.2 for a very long period of time, and if I did an exam on that man and his prostate felt normal, I would feel
Yeah.
comfortable starting that man on therapy.
It's
I would
it's
not.
it's trends. That's the
It's
thing.
trends, yeah,
Because when
yeah.
because we tend to monitor PSA in a lot of our
Mhm.
guys, and it's so you can see fluctuations of quite a massive degree. One week you can be like, oh my god, he's got prostate cancer. The next week you repeat it and it's completely normal. It's dropped by 200%, and there's a lot of fluctuations day to day. So the biggest deal, like you say, is often the trend. If they've got a stable PSA level, their prostate's been checked at some point, then there's not an overt concern with that, is there?
Yeah, yep. Yeah, I don't get too worked up about that. At
Mhm.
least not as much as I used to. Just now as we get a better understanding of how prostate
Yeah.
cancer works and the limitations of some of these studies. So the next one, and this will probably be one of the last, ones that are typically found in most guidelines, is um, you know, elevated hematocrit at baseline.
Mhm.
And so
Mhm.
you'll hear different numbers depending on the guidelines, 48%, 50%, et cetera. Um, what are your thoughts on that?
Well, I think the problem with hematocrit is, again, like it's so variable depending on how hydrated the person was.
Mhm.
What's their
Sure.
state of play when they come into the test. I think that the fear is presumably that they've got an undiagnosed blood disorder or a
Right.
polycythemia vera.
Right.
So I kind of, often in those circumstances, it's a case of, were you hydrated at the time of the test? Because you'll often get a raised hematocrit and they'll be like, oh, no, I was
Absolutely.
fasted. I thought I wasn't meant to drink for
Right.
20 hours or, like an operation or something. So often if the hematocrit is a little bit raised and we have an explanation, it doesn't freak me out. If it's
Exactly.
if it's very raised, then more than anything, you want to work out why, particularly if they've come in hydrated, then you might be looking at sleep apnea or,
Absolutely.
yeah. So
Yeah.
if you can explain the hematocrit, it doesn't concern me. Or if it's on the other side of that, if it's particularly high, then I just want to know why it's raised more than anything.
Precisely.
Yeah.
Yeah, I feel the same way. It's not in and of itself is not a contraindication. It's what is driving that hematocrit.
Yeah.
If your patient, for example, lives in the Swiss Alps and they fly over to the UK to see you, you wouldn't bat an eye. You'd expect them to be, if they live at 4,000 meters or whatever, you're going to expect them to have an elevated hematocrit, and you know exactly why. And do they have untreated sleep apnea? Smokers a lot of times have high hematocrits for obvious reasons. So yeah, I think it really depends on what the underlying condition is.
Yeah.
You and I both, I think, we don't get too worried about these hematocrit elevations within reason. Certainly within, that sort of like 50 to 55% range, which is where a lot of men end up. They're just, all other things being equal, there's just not great evidence that there's risk in that range.
Yeah.
From TRT, for example. Now, if you have a baseline hematocrit of 52 or 53%, not on TRT, again, that's a reflection of some pathology. And so it's the pathology that's the danger, not so much the hematocrit.
Yeah.
But I fully recognize there's still a bit of controversy in there. And then, what do you do with these extreme hematocrit elevations on TRT? That's a whole nother ball game when guys are 58, 60, 62. Nobody knows for sure exactly what to do with those guys, in my opinion. So
I think that's slightly as well. I've spoken to other, I don't know, we've discussed it before, but in the UK, I don't tend to see the higher levels of the hematocrit, and I don't exactly know why. Some guys 52, 53, 54, I don't bat an eyelid. That's pretty...
That's expected.
Expected. But the higher levels, I've never really come across, except if that guy was particularly dehydrated on the day.
Yep.
So I don't know what the difference is, whether it's just on the forums, you do tend to see the worst cases because it's people who are not the common ones. Yeah,
there's going to be a little bit of selection bias. Yeah, exactly. Nobody takes time to go on the forums and brag about their hematocrit of 49%. But they want to let everybody know that they were 58%. Yeah. I've seen it a couple of times, and it's obviously it tends to be an elderly man. The older you are, for whatever reason, there tends to be a bit more erythrocytosis. It's almost always with injectable testosterone, obviously. Yeah. And so again, that's a whole nother podcast to get into. But again, I don't freak out about it. There's a small subset of like rare patients that, for example, have mechanical valves, and I wonder if, okay, then I might need to be paying a little bit more attention to viscosity issues. I don't want to stress that valve. And that sort of thing. So those are tough cases that nobody has great, obvious answers to. So those are all sort of rare case by case things. But I have had a guy that had a mechanical aortic valve, and he was doing great. He had a congenital bicuspid valve. He needed to end up with a mechanical valve, but I did worry about him getting a elevated hematocrit, 52, 53, 54, because that, at least in my mind, I feel like that could impact the hemodynamics of the valve and also like the structural integrity. I want him to, I want that valve to outlive him, basically. I'd hate for him to have to go back and have a valve replacement because of extra.
The other thing would be using the compounded cream, I guess, as well. That would be an alternative option. Sure. Just because you don't tend to see these hematocrit elevations.
That's true.
With it.
Yeah, it's right. Yeah. In theory, you should have just as much hematocrit elevation because obviously it's based on serum levels. But in clinical practice, I just don't seem to see that quite as much, probably due to the daily variability, And I am a fan of compounded cream for just because of what I've seen with patients. I know there's a lot of docs on the forums that you and I both know who are very strong advocates of cream.
Hmm.
I personally have never used it because I'm just happy with my injectable routine, but patients tend to do very well with it. Haven't had too many failures. You hear about them on the forums, but cream didn't work for me.
Hmm.
Okay, well, I don't know the details of that, but um, I just don't see too many treatment failures with it.
Yeah. Well, you wonder
Personally.
then about like, was the dosing right? Were you sticking to the application advice? The whole cream,
Yeah.
like shave scrotum, that
Mm-hmm.
sort of thing. You wonder.
Mm-hmm.
You never
Mm-hmm.
know because you don't know the details.
Yeah.
Yeah. But there will probably be a small percentage who just don't absorb it well, or it's like the injections. A small percentage don't get on with the injections. You switch them to cream and they feel better.
Mm-hmm.
Kind of like
Mm-hmm.
we're all a bit different.
Mm-hmm. One of the other things, just to kind of go on with this hematocrit thing, because obviously the concern with elevated hematocrit is thrombosis, right?
Yeah.
Deep venous thrombosis, pulmonary embolism, stroke, MI, etc. So this is sort of a bit more of an advanced case or advanced situation. Is what do you do with the guy who's had a DVT in the past and either had a negative workup for many of the genetic conditions, or finds out in the course of that workup, for example, they have factor V Leiden, or they have antithrombin 3, or one of these hereditary clotting issues, but he comes in highly symptomatic with a low testosterone, and there's no guide, like the guidelines just are like they don't want to go
Mhm.
there. And I understand that because I don't think anybody has a great answer about what to do with those guys. But I do have a patient that has a hereditary thrombophilia, and he was already on testosterone when he came to see me. But those are cases like I just think you have to have a good conversation with patients. The data is overwhelming that TRT in and of itself is not, doesn't pose a thrombosis risk.
Mhm.
But again, I hate to have to think this way, but at least in the United States, if a patient's with one of those known conditions who's had a clot before is on TRT, if they get another clot, who's going to get blamed for that.
Yes.
Uh,
Yeah.
yeah,
100%.
and it will
Yeah.
be they won't have a hard time finding an attorney, and they won't have a hard time finding an endocrinologist who, for a generous fee, will get up in front of a court, in front of a jury, and point the finger at you and say you caused this person's DVT.
Mhm.
When the reality is like they can't prove that. They would have gotten a DVT anyway in many cases, especially if they're not anticoagulated. So I don't know. Have you come across that issue? I've
Fortunately
had it one
not.
time. What's
Fortunately
that?
not. No,
Yeah,
fortunately not.
yeah,
I probably would lean on the topical then. Probably I'd be like, I think you should try the cream.
yeah,
Yeah.
yeah, yeah. But those are the tough issues. Most TRT is, let's face it. I mean, it's in healthy, otherwise healthy men without major medical issues, or maybe just they've got a little bit of cholesterol issues, they've got some blood pressure issues, they need to lose some weight. It's not rocket science.
No.
You have to be prudent, you have to know your stuff. But again, it's these more complicated cases that kind of keep me up at night sometimes. Is how do I approach these people again with mechanical valves? They have severe heart failure. They've got 3 or 4 stents. Oh, and by the way, yeah, you've got factor V Leiden, and you nearly died from a saddle pulmonary embolism 10 years
Mhm.
ago, and
Mhm.
you're anticoagulated on warfarin.
Yeah.
Like, uh, yeah, there's the guidelines are strangely silent on what to do
Yeah.
with guys like that. So, but I'll be honest. I mean, maybe I'm a bit of a cowboy. I don't think I am. I think I'm fairly conservative. I have, as the years go by, I have less and less problem treating even people like that. I just do
Yeah.
it prudently because they do. I mean, the data is overwhelming that there is benefit in so
Yeah.
many areas, and even if it's just quality of life in
Mm.
these guys, I will tend to want to treat them because I know I can make a difference in their overall health.
Yeah, and we know very well that low testosterone is not good for your
No,
health
no.
long term. So it is becoming more overwhelming that actually TRT is very, very, very likely better than low T for your health.
Yes,
Yeah,
I think that's a safe
yeah,
statement. So
yeah.
yeah, just to wrap this up, I guess, despite what you hear on the internet, despite what you may read about in forums or you might hear from your friends at the gym, TRT is not something to be taken lightly. And I think it's really, really important to look into the downsides of testosterone. There are many. Fertility, again, we talk about that a lot because of our personal issues and our personal journey with that. But there's many other things as well. And I think if you can do anything you can do to avoid or delay being on TRT, especially as a young man under the age of 30, I think you really should exhaust all of those options. And to the best of your ability. I understand it's difficult. I understand that in many cases it won't be successful. That's just the nature of the condition. But that doesn't mean you still shouldn't try. Everybody who is 30% body fat, I feel confident saying anybody who's 30% body fat will feel better and benefit in the long run by even coming down to 25%. And you don't have to be on TRT to do that. You can still be hypogonadal and lose body fat. I understand it's just harder. I understand that.
Yeah.
Just like losing weight is hard, losing weight with a GLP-1 is easier. And you can just insert testosterone for the GLP-1. It lowers the barrier to achieve that goal, but there's a cost to that. So I just want guys to think about that. Just pause for a little bit as you scroll through your Instagram feed, and you see all the TRT related content.
Yeah, it's not as simple as just jumping on it. I think that's the thing.
No,
isn't it?
No, you don't want to jump. You don't want to jump on anything that's a lifelong therapy. You want to really think about it. And I tell guys, like, who are married, talk to your wives about this. Make sure they're on board with this because they're along for the ride as well. So talk to family members, talk to other people that care about you. And
the wife might be the one who injects you, like me.
Precisely. Yeah, exactly. Yeah. Right. So you better be nice to her.
My shoulders are too wide to inject myself, you see.
I get it. I understand. Yeah, it's a burden. It's a burden you bear. Yeah. It's a tough life. Cool. Well, anything else you want to add in there, Max, before we call it a day?
No,
it's been a great podcast as usual.
Hopefully it's just useful for people. Yeah. I don't want to be overly negative about TRT whatsoever. It changed, my life completely. But it's, you need to know the ins and outs of it before you go down that route. Yeah.
Yep. Yeah. Don't go into it blindly.
Yeah.
So cool. All right. Thanks, Max. Appreciate it, man. We'll do this again. I would ask if anybody has had negative experiences with TRT. We always hear the positive, and I love the comments. So please leave some comments in the on the video. But if you have anything you want to share in terms of downsides, I certainly enjoy hearing from you guys, but other people that watch this video might appreciate hearing your story as well. If there's been some downsides to testosterone. So feel free to leave those in the comments. So, all right, guys, we'll catch you next time. Thanks so much. Max, thanks again, buddy.
Cheers.
Talk to you later. Bye. All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.